For the brachial plexus, the learning objectives will be to know the origin of the elements of the brachial plexus, to get a sense of where the different segments of the plexus would be. In other words, the roots of the brachial plexus, which are very important. The trunks of the brachial plexus are also important. And then we'll talk about the divisions, the chords, and especially the branches, and see what they are involved with. We're going to have to understand the relationships of the elements of the brachial plexus because the surrounding structures are particularly important in that relationship. We need to know what each branch of the brachial plexus will supply, so we're going to look at the general rules that are particularly important and helpful to know for long stream retention of information. Then we can look at common sites for accessing nerves. They are also common sites for nerve injuries because of their accessibility. So if we look at the shoulder, we can see the deltoid muscle. Those are the anterior fibers of the deltoid. Deltoid's a particularly interesting muscle because it has three component parts. It's got an anterior segment we see here, a posterior segment that is much the same, and then this lateral aspect. And the deltoid as a muscle actually assists with all actions that are occurring at the shoulder. The pectoralis major muscle, also an interesting muscle. Anytime we have a triangular shaped muscle or some muscle that's not just tubular, it's going to have multiple actions. So like the deltoid, the pectoralis major assists with many actions at the shoulder. These fibers, the clavicular head, for example, assist with flexion at the shoulder. And interestingly, the most inferior fibers that course underneath and attach fairly high on the humerus from a flex position can assist with extension. So one muscle that can oppose its action, and the same thing is true with the anterior fibers of the deltoid, assist with flexion, while the posterior fibers will assist with extension. So the interesting thing is the elements of the brachial plexus that supply these muscles will drop specific spinal segments, specific fibers to different regions, and the muscle can contract regionally rather than as a full entity. The deltopectoral triangle is a region that is between the deltoid muscle and the pectoralis major muscle and the clavicle, a little triangle there. And this cephalic vein, which is an interesting structure, begins on the dorsal venous arch of the hand and travels all the way up the extremity to dive deep and go into the axillary vein or the subclavian vein. There is variability in that. The elements of the brachial plexus lie within the posterior triangle of the neck, and that's what we see here. The posterior triangle is anterior to the anterior edge of the trapezius, posterior to the posterior edge of the sternocleidomastoid muscle, this being the trapezius again, and superior to the clavicle. So this triangle that is formed here is called the posterior triangle of the neck. And within that posterior triangle, there is a subdivision called the subclavian triangle. And within that triangle, one will find the subclavian vessels, artery and vein, which are very large vessels, and the elements of the brachial plexus. So subclavian triangle, again, deep and inferior to this muscle, which is the omohyoid muscle. This is the inferior belly of the omohyoid muscle. So if we remove the connective tissue that we saw in this particular view, if we open up that connective tissue and we remove the omohyoid muscle, cut there, and reflect the sternocleidomastoid, the clavicular head of the sternocleidomastoid, we can open up this posterior triangle so that we can see the elements of the brachial plexus and the subclavian vessels that we want to investigate. The anterior scalene muscle is a landmark that is very important. It lies anterior to the elements of the brachial plexus and the subclavian artery. The anterior scalene muscle comes from the transverse processes of cervical vertebrae, and it extends down and attaches to rib 1 anteriorly. The C5 root of the brachial plexus we can see here exiting again posterior to the anterior scalene muscle. There is the C6 root of the brachial plexus, C7, C8, and T1. So those are the elements that will be the origins of the brachial plexus, again called the roots of the brachial plexus, C5 through T1. They are sandwiched between the anterior scalene that we see here, the middle scalene muscle that is immediately posterior to the roots. There is also a posterior scalene that is posterior to the middle scalene. So again, anterior and middle scalene muscles with the brachial plexus and subclavian artery between, and then posterior to the middle scalene will be the posterior scalene muscle. Not usually an important landmark. It is deeper to the middle scalene and then simply goes and attaches to rib 2. Anterior and middle scalene, their inferior attachment is rib 1. On either side of a little depression that is created by the subclavian artery. So the top of rib 1 has that slight depression, scalene muscles attaching on either side of the depression. The subclavian artery, again, is usually located inferior to the T1 root. That is not 100%. Sometimes the T1 root and even the C8 root can be located posterior to the subclavian artery. That is important. That's important when one is doing ultrasound or trying to do anesthesia in the neck region with a interscalene or interscalene block. It's important to understand that the T1 root especially could be protected by the location of the subclavian artery. The axillary artery is the continuation of the subclavian artery once the vessel crosses rib 1. So it simply transitions from subclavian to axillary after crossing rib 1. The subclavian vein parallels, of course, the subclavian artery. There is, again, a transition into axillary downstream, but or actually that's upstream for the vein. But the vein, the interesting thing about the vein is it lies anterior to the anterior scalene muscle. So we now have vein anterior to the muscle and the artery posterior to the muscle. Again, important relationships in this region. So one needs to familiarize themselves with those relationships. The phrenic nerve is another structure that is on the anterior surface of the anterior scalene. So structures we see anterior to the anterior scalene, again, subclavian vein and this phrenic nerve. There are a couple of arteries that cross anterior to the anterior scalene. The transverse cervical artery, transverse cervical, and the suprascapular arteries. Transverse cervical is going to supply the trapezius and the rhomboids with blood, and the suprascapular will supply the muscles of the scapula, rotator cuff muscles, supra and infraspinatus. So they do, again, cross anterior to the anterior scalene. They are branches of the thyrocervical trunk, a branch of the first part of the subclavian. So we can see those crossing this region. The cervical region, if we make a cross-section of the cervical region, we can get a sense of where these structures are that we have just discussed. So there is the anterior scalene muscle. We can see it attaching to the transverse process of one of the cervical vertebrae. And again, will extend down to rib 1. The middle scalene is in this particular area, and there is the posterior scalene. So we've got anterior, middle, and posterior, and we've got an element of the brachial plexus sandwiched between anterior and middle scalene muscles. The phrenic nerve, again, traversing on the anterior surface of the anterior scalene with a very important relationship there. The vessels contained within the carotid sheath, we will have the common carotid and the internal jugular vessels, and the vagus nerve will be in the cleft between the common carotid artery and the internal jugular vein. And again, those sit just as you can see, just anterior to where the phrenic nerve is. The brachial plexus itself is of a complex mixing of the nerve fibers from the roots of the brachial plexus. So we again have the C5 root, and specifically the dorsal root ganglion can be observed here. So there is where the sensory cell bodies live. And we have, so that is going to be the sensory portion. This is the motor portion. So that'll be the ventral root off of the spinal cord, forming the spinal nerve. So there is the spinal nerve from C5. We then have the same for C6. Those two will join together. The fibers will get wrapped up and form what's called the upper trunk. So this is the more superior of the trunks, so it can be called superior trunk or upper trunk, again, formed from the union of C5 and 6 spinal segment. C7 by itself forms the middle trunk, and then C8 and T1 form the lower trunk. So we have superior, middle, and inferior, or upper, middle, and lower trunks. Upper 5 and 6, middle by 7, and lower trunk C8 and T1. Off of each of the trunks, we have a posterior division. These posterior divisions from each one of the trunks will join to form the posterior chord. The reason it's called the posterior chord is the subclavian artery, which we know originated from the inferior, just inferior to where T1 was. That artery will then be placed in that location, just anterior to the posterior chord. So again, posterior to the subclavian artery, or actually, pardon me, it's now called the axillary artery because it has crossed over rib 1. So subclavian in this location, axillary artery once it crosses rib 1. So again, the posterior chord lies posterior to the axillary artery. The posterior chord will give rise to some large branches, the radial nerve seen here, and the axillary nerve. We will see that the radial nerve goes down the posterior aspect of the arm and forearm, where the axillary nerve will supply the shoulder. The anterior division of the upper trunk joins with the anterior division of the middle trunk, and those two will come together to form the lateral chord. Again, lateral to the location of the axillary artery. The anterior division of the lower trunk by itself forms the medial chord. So the anterior division of the lower trunk from C8 and T1 will give rise to the medial chord, again with those same spinal segments, C8 and T1, medial to the axillary artery. So the interesting thing is these are anatomically named. The upper, the middle, and lower trunks, when we get into the extremity, down into the upper extremity, the relationship is now lateral at the chord level to medial. Lateral chord, medial chord, again lateral and medial to the axillary artery with the posterior chord lying behind. So they are named by their relative position in the anatomical sense. The lateral chord and the medial chord have a lateral and medial branch that come together to form the median nerve. This nerve will be important in the anterior aspect of the forearm and into the thumb. Off of the lateral chord, we also have a musculocutaneous nerve, and that will supply, as we will see, the anterior muscles of the arm. And then the ulnar nerve from the medial chord is going to supply just 1.5 muscles of anterior forearm, but most of the muscles that are intrinsic in the hand. The rule of threes that I used when I was trying to learn the brachial plexus, I think is very helpful. So we have seen the main branches like the radial and the axillary and the musculocutaneous, etc. So now we want to find some of the minor branches that we have. And again, using the rule of threes, it helps us get a sense of what those might be. So if we take a look at proximal branches, where the box is indicated, we have a very important nerve called the long thoracic, and that has fibers from spinal segments C5, C6, and C7. Remember that this was the C5 root, C6 root, and C7 root. So the long thoracic is formed from the union of fibers from those spinal segments. That particular nerve will supply the serratus anterior muscle. So we can see this thin nerve coming out of the cervical region. It will course through the axilla and be on the lateral or superficial surface of the serratus anterior muscle. So it is commonly injured. And again, damage to that particular nerve causes a condition called winging of the scapula. The C5 branch to the phrenic nerve is also seen in this area of 3 branches. So the phrenic nerve contains fibers from C3 and C4 out of the cervical plexus, and then C5 from the brachial plexus. So C3, 4, and 5 keep the diaphragm alive. That's the phrenic nerve. And the third one in this proximal region is the dorsal scapular nerve, specifically just from C5 spinal segment, and it supplies the rhomboid muscles, rhomboid minor, rhomboid major, that are on the posterior surface, part of the extrinsic muscles of the back. So long thoracic, dorsal scapular, and the C5 component of the phrenic are the 3 that we see in this proximal region. If we continue the rule of threes and look at the 3 lateral branches, we will have the nerve to the subclavius. The subclavius muscle is seen on the bottom of the clavicle. Not particularly important from a functional standpoint, other than the fact that when we have clavicular fractures, that muscle is actually somewhat protective of underlying structures like the lung to keep the clavicle from puncturing some of those structures, the lung or the subclavian vein, etc. The suprascapular nerve is going to go to rotator cuff muscles. So that's C5 and 6. It's going to go above the scapula, hence the name suprascapular, and it will supply the supra and infraspinatus muscles, 2 of our rotator cuff muscles. C5 and 6 will be the spinal segments that will be involved with innervation of shoulder structures. So when one thinks of shoulder, one thinks of C5 and C6. The third nerve in this group will be the lateral pectoral nerve. The lateral pectoral nerve will be formed once we get the anterior divisions off of the upper and middle trunk, forming the lateral chord. And so C5 and 6 from the upper trunk and C7 from the middle trunk will form that lateral chord. and the lateral pectoral nerve will consequently have spinal segments C5, 6, and 7. And that will be going to the pectoralis major muscle to supply especially the clavicular head of pectoralis major. If we continue with the rule of threes and look at the three medial branches in the box shown, we have the medial pectoral nerve, which supplies pectoralis major, but also pectoralis minor muscle. And because it's off of the medial chord has spinal segments C8 and T1 contained in it. So those are the fibers in the medial pectoral nerve. Then we have two cutaneous branches. One is the medial cutaneous branch of the arm, and it will supply the skin of the medial arm, as the name suggests. It does not supply any muscles, only area of skin. And then the medial cutaneous nerve of the forearm. So again, like the medial cutaneous nerve of the arm, this is simply going to be supplying skin of the medial aspect of the forearm, no muscle branches. And those are essentially from C8 and T1 as well. The medial cutaneous nerve of the arm is also called the medial brachial cutaneous because the arm is the brachium, and the medial cutaneous nerve of the forearm is also called the medial A-N-T-E, brachial cutaneous nerve, because the forearm is the antebrachium. Continuing our rule of threes, we have three posterior branches, three branches off of the posterior chord. The most proximal of those is the upper subscapular. This will be going to the subscapularis muscle, which is another one of our rotator cuff muscles, this one being on the anterior aspect of the scapula, and will go and attach to the lesser tubercle of the humerus anteriorly and be an internal rotator at the shoulder. Because it's supplying muscles of the shoulder, it will have spinal segments C5 and 6. Now this can be a bit confusing because if you see where this comes off, again, off of the posterior chord, we can remember that the posterior chord is formed from posterior divisions of upper, middle, and lower trunk. And the upper trunk, again, is from C5 and 6. The middle trunk is from C7, and the lower trunk is from C8 and T1. And one would expect that all of the branches that come off of the posterior chord will contain spinal segments from C5 through T1, but that's not the case. Even though all of those spinal segments are in the posterior chord, each of the nerves that peel off from it don't necessarily contain all of the spinal segments. So most of the branches of the brachial plexus are predictable based on where they come off the brachial plexus. These three off the posterior chord are not necessarily predictable, and they have to be learned differentially. And so the subscapularis, again being a rotator cuff muscle, is a muscle of the shoulder, and all muscles of the shoulder are supplied by C5 and C6. So the nerves coming off of the brachial plexus, even coming off the posterior chord, will contain those spinal segments. So upper subscapular, 5 and 6. The middle subscapular is more commonly called the thoracodorsal nerve. The thoracodorsal nerve goes to the latissimus dorsi on the back, and that particular nerve is comprised of fibers from spinal segments C6, C7, and C8. The lower subscapular nerve supplies subscapularis, again, that rotator cuff muscle, but it also supplies the teres major muscle. This is a muscle coming off the lower portion of the scapula that crosses internally and attaches anteriorly on the humerus and is an internal rotator right along with the subscapularis. The lower subscapular, going to muscles of the shoulder, contain fibers from C5 and C6. If we take a look again at the brachial plexus and look at the relationships and the configuration we have, we again see our roots of the brachial plexus, C5 through T1. We talked about their position relative to the anterior scalene muscle. We talked about the relationship of other adjacent structures that will be posterior to the anterior scalene. In other words, the subclavian artery that similarly lives in that location. We talked about the structures anterior to the anterior scalene, like the phrenic and the subclavian, the transverse cervical and suprascapular arteries. So we have an idea of the relationships in that particular region. If we travel down further and look at the axillary artery, again, the continuation of the subclavian once we cross rib 1, we can see again that the lateral chord of the brachial plexus lies lateral to that anterior scalene as we go into the extremity, lateral to the axillary artery once we get into the extremity. And the medial chord will be medial to the axillary artery once we head down into the extremity. We do not see the third chord, that is the posterior chord, because it is posterior to the axillary artery. So relationships here are very important. The thing that is not observable here is that all of these structures are enclosed within some axillary fascia. So the entire brachial plexus down here in the axillary region and the vessels, including the vein, including the axillary vein, will be enclosed, if we had the vein in place, will be enclosed in this fairly dense connective tissue, containing it, supporting it in that particular region. If we get down into the rest of the extremity, we can see the origin and the continuation of the branches of the brachial plexus. We want to follow those branches down into the upper extremity and gain some sense of what they will do. So because no one ever gets into trouble because they know too much, we're going to review these individual branches and take them down into the extremity. So off of the posterior chord, we have the axillary nerve. We know that the axillary nerve has spinal segments C5 and 6 in it because we know the axillary is going to the shoulder region. If we look at where the axillary nerve is, it is coming again from C5 and 6 and going through a space called the quadrangular space, and you can see that small space right here. It is actually between what is called the teres minor muscle and this one, which is the teres major muscle. So it's in between the two of those, inferior to teres minor, superior to teres major. Then just medial to the surgical neck of the humerus and lateral to the lateral aspect of the long head of the triceps. So those are the boundaries of the quadrangular space that we can see here. It travels with the posterior humeral circumflex artery in that location. Because of the location of that particular nerve, it is very susceptible to injury when we have dislocation at the shoulder. So if the head of the humerus is dislocated, it usually ends up in an anterior inferior location. And that action alone of dislocating can cause trauma to the axillary artery, or in some cases, reduction of the humerus into the glenoid fossa that we can see here. That process of reduction, if not done carefully, can entrap the axillary the axillary nerve or the posterior humeral circumflex artery in the shoulder joint. So it does happen that it can be entrapped in there or damaged due to, again, the process of dislocation. Additionally, because of the proximity to the surgical neck of the humerus, fractures of that surgical neck can damage the axillary nerve. So those two things are particularly important: dislocation, shoulder dislocation, or fracture of the surgical neck of the humerus. The muscles that it will supply will be the deltoid muscle that we talked about previously, and the teres minor muscle, the one just superior to the quadrangular space. So the teres minor is a lateral rotator at the shoulder. Again, importantly, a rotator cuff muscle, and those rotator cuff muscles are particularly important in maintaining the integrity of the shoulder. They hold the head of the humerus up against the glenoid fossa of the scapula. Damage to the rotator cuff muscles or their nerve supply, causing laxity in this region, creates a situation where shoulder dislocation becomes common, and one has to repair those muscles. The deltoid muscle we talked about previously is a complex muscle with anterior, posterior, and lateral fibers. And those fibers can assist with every action at the shoulder. The anterior fibers can assist with flexion and internal rotation at the shoulder. The posterior fibers assist with extension and lateral rotation at the shoulder. The lateral fibers are very important in the process of abduction. If we are in an abducted position, we can use the anterior and posterior fibers to assist with adduction against resistance. So again, all actions at the shoulder are accomplished with or assisted by the deltoid muscle. Very important muscle. The muscle will be cutaneous to the lateral aspect of the shoulder. In other words, the skin that overlies the deltoid muscle. We'll see that in just a second. So this gray area is the area that is going to be supplied by the cutaneous branches of the axillary nerve. So that area of skin, and we see it on the posterior surface, and importantly, it comes all the way around to the anterior surface. So the skin over the deltoid is supplied by the axillary nerve. Continuing with the posterior chord, we look at the very large radial nerve. The radial nerve, appropriately coming from the posterior chord, is formed by the union of fibers from all spinal segments via these posterior division components. So it is supplied or contains fibers from C5 through T1. The radial nerve, seen here, again containing fibers from all of the spinal segments of the brachial plexus, will be in the triangular interval, and that's this space seen here. The triangular interval is just inferior to the teres major muscle, seen right there, and it is just lateral to the lateral aspect of the long head of the triceps, that's seen here, long head of the triceps, and it is just medial to the mid portion of the shaft of the humerus. So it travels with the deep branch of the brachial artery, the profunda brachii, and it supplies the muscles of posterior arm that are seen here, the triceps muscle specifically, and the muscles on the posterior aspect of the forearm, which are very complex. There are several of them. So the cutaneous portion of the radial nerve will supply the posterior arm and posterior forearm skin, and importantly, it will go down to the dorsal aspect of the hand, where it will supply the skin of the lateral 3.5 digits. So posterior side, dorsal side, the back of the hand, lateral 3.5, in other words, the thumb, the index finger, the middle finger, and half of the ring finger. lateral side. But it does not supply the region of the nail beds. So the branches come down and they stop before they get to the nail bed region. Where they stop is variable, but they will stop before the nail bed. The skin of the nail bed, sensory to that particular region, will actually be branches that come from the palmar surface. That will be the median nerve for the lateral 3.5. And they will send branches around to get to the skin. Now, each one of our digits, if we took a cross-section through a digit, and we will say that this is posterior and this is anterior, we will find that on each side there will be paired branches, 2 on the posterior surface, 2 on the anterior surface. So there are 4 branches that parallel each other, traveling down each digit. So again, using the radial nerve to the index finger, these paired on the posterior side will stop short of the nail bed, and the paired branches from the median nerve, which we will see later, coming down on the palmar side of the index finger, will also send branches around to get to the nail bed. Very interesting situation. Very important to remember, especially for anesthesia purposes. If we continue with the radial nerve down into the forearm region, again, complex because of the number of muscles we see there, we can see that the nerve lives anterior to the lateral epicondyle. That lateral epicondyle is actually cut away here. We really shouldn't see the nerve if the bone is intact, so it should be sitting over the top of, if you will, that particular nerve. But since it's cut away, we can see that. So again, the nerve comes from the posterior chord of the brachial plexus, travels around the middle of the shaft of the humerus, where, again, mid-shaft humeral fractures can damage the radial nerve. And so it then comes around and goes anterior to the lateral epicondyle of the humerus. So fractures of the lateral epicondyle can damage the radial nerve in that location. One other place proximally that the nerve can be damaged is up in the axilla. So if one is using crutches and puts too much weight of the body onto a crutch, one can damage the radial nerve and have what's commonly called crutch palsy. There is another condition called Saturday night palsy, and that occurs when someone falls asleep with their arm over the back of the chair, maybe after a night of partying, and they compress the radial nerve. So it can be compressed in the axilla. It can be damaged with mid-shaft humeral fractures. It can be damaged with fractures of the lateral epicondyle, which brings us down to this level. So from that point, the nerve, the radial nerve, will branch into the superficial branch, which is the cutaneous one that we see coming down into the hand, supplying the lateral 3.5, and a deep branch, which is a motor branch, which is going to supply, in some manner, the muscles of the posterior aspect of the forearm. So that deep branch, interestingly, will course through this muscle, which is called the supinator. And the supinator does exactly what its name suggests. When we have our extremity down next to the side of the body and the palm is facing posteriorly, it's in a pronated position. So that position of my palm is pronated when it's straight down. So that's pronated, and if I bring it anteriorly, if I rotate anteriorly, that is now supinated. So the palm is now anterior. Palm posterior pronated, anterior supinated. So this particular muscle will take the radius and rotate it around the ulna. to supinate. It's a little hard to see, but one needs to look at this on the skeleton. So it's attached to the anterior lateral aspect of the radius and goes around posteriorly and attaches to the shaft of the ulna right over here. So again, when the muscle contracts, it brings those 2 points closer together. So it takes the anterior lateral aspect of the radius and brings it closer to where it attaches on the ulna. And that process is supination. Now, the interesting thing about the nerve is this deep branch courses through the supinator, as seen there. So the supinator has been cut away a bit so that one can see the nerve coursing through it. So in most of us, it goes through the width of, the substance of, that supinator muscle. Well, that is normally not a problem unless somebody is now doing a lot of supination and pronation. So for example, if an individual gets a job as a mechanic after not having done this work, and they're using the wrench and doing a lot of supination and pronation, or with a screwdriver, a lot of supination and pronation. And that muscle compensates for that increased activity by increasing in size, by hypertrophying. If that is done over a short term, that hypertrophication can cause compression of the deep branch of the radial nerve. And then the muscles that are downstream would be affected because the nerve is not functioning properly because it's compressed. Nerves don't like to be compressed. So the downstream nerve is the continuation of the deep branch, now called the posterior interosseous nerve. And the posterior interosseous nerve supplies a lot of the muscles that are down in the distal part of the forearm, especially things like wrist extensors and digital extensors, the ones that do extend the digits of the hand and work on the thumb. So those muscles could be affected. One of the things that's particularly interesting is if we want to hold things tightly, that's called having a good power grip. So if we want to hold a tool tightly or a hammer, for example, we end up being slightly extended at the wrist. So if you take any tool, for example, and you grab it tightly, you automatically extend slightly at the wrist. And that allows you to have better leverage of the finger flexors so that you can hold more tightly. So if you lose that ability to have that slight extension at the wrist, you lose the ability to have a good, strong grip. So the power grip is affected. The power grip, that's what it's called. So if the deep branch of the radial nerve were compressed as it courses through the supinator by hypertrophication of that supinator, the posterior interosseous nerve loses some of its function and the muscles downstream are affected, and the first sign of that is loss of the power grip. To let you know how important that is, a self-defense move, a typical self-defense move, if somebody is being attacked, say with a knife, one of the easiest ways to disarm the individual is to do what's called break the wrist, which means you force them to lose that power grip and they can no longer hold on to whatever tool it is that they were holding, knife or whatever. So it just shows how important that power grip is. So that's the radial nerve, again, damaged in the axilla, damaged in the midshaft of the humerus, damaged at the lateral epicondyle, damaged as it courses through the supinator. Each one of those positions are possible. The cutaneous distribution of the radial nerve is seen here in pink. So the posterior aspect of the arm, posterior aspect of the forearm, posterior aspect of the hand, the lateral 3.5 digits. except for the nail beds. So again, not the nail beds. Going to the lateral cord, the musculocutaneous nerve is going to be supplied from C5, 6, and 7. So it comes from the lateral cord. The lateral cord has anterior divisions of upper and middle trunk. The upper trunk, again, from C5 and C6, and the middle trunk from C7. So that is the composition of the musculocutaneous nerve. The musculocutaneous nerve, again from 5, 6, and 7, courses through this particular muscle, the coracobrachialis. Coracoid process to the midshaft on the medial side of the brachium or the humerus, coracobrachialis. So it goes through the muscle most of the time. Unlike the situation with the radial nerve and the supinator, this does not usually cause a clinical situation. So it's difficult to hypertrophy the coracobrachialis by itself and compress the musculocutaneous nerve. Part of the reason is it just goes through it, transversing the muscle rather than coursing along its full width. The muscles that it supplies are the muscles of the anterior arm, the coracobrachialis, the biceps brachii, and the brachialis. So those three muscles. Those three muscles are important for shoulder flexion. They are important for elbow flexion. And interestingly, the biceps, as it attaches to the radius, the radial tuberosity, it is important also in the action of supination, but when the elbow is in a flexed position. So when you pronate, this particular tuberosity on the radius actually rotates posterior medially, and so it's in that position when the forearm is pronated. When the biceps then contracts, it will pull that radial tuberosity more anteriorly and, again, assist with the process of supination. So cutaneous will be those areas that we see in green, which will be the lateral aspect of the forearm. So even though it supplies muscles of anterior arm, its cutaneous distribution is down in the forearm on the lateral side. It's rather unique. We see a similar situation with the femoral nerve down in the lower extremity, supplying anterior thigh muscles, but skin also way down into the medial aspect of the leg and foot. If we take a component of the lateral cord plus a component of the medial cord, so lateral branch and a medial branch, if you will, we form the median nerve. So we get 5, 6, and 7, spinal segments 5, 6, and 7 from the branch from the lateral cord. We get C8 and T1 from the branch from the medial cord. And we form the median nerve, which lives at the center of this M. So the orientation in the anatomical situation is very helpful with understanding that the median nerve is the center of the M. So you can see that here. So there comes the median nerve. Again, containing fibers from all of the spinal segments from C5 through T1, because, again, the contributions from lateral and medial cords. The median nerve does not do anything in the arm. So the median nerve, we can see it really being important in the forearm, again, being comprised of spinal segments C5 through T1. The only thing that's of significant concern in the medial aspect of the arm is the fact that the nerve is fairly superficial. It can be accessed for anesthesia purposes. It can be accessed from trauma purposes. So anything that may damage cause trauma to the medial aspect of the arm can get this particular nerve. Interestingly, it can also be damaged in the cubital fossa, which is the anterior aspect of the elbow, because it's fairly superficial. There is a relationship called TAN, tendon, artery, and nerve, that exists at that region of the elbow. So the nerve is very superficial. So one is, when one is trying to draw blood from the cubital fossa, the nerve is pretty superficial and can be, in an inexperienced phlebotomist, damaged by improper technique. So it's important to remember that it exists in that location. Again, there are no branches in the arm supplying any structures in the arm per se, but it does supply the muscles of the anterior forearm, except for 1 1/2. Those will be supplied by the ulnar, and we will talk about those momentarily. It also, most of the muscles of the arm, in other words, the flexors of the digits, so flexor digitorum superficialis, part of flexor digitorum profundus, the muscles that will assist with abduction at the wrist, so flexor carpi radialis also assists with flexion at the wrist. So those are guys that will be supplied by this particular median nerve, including a muscle called pronator teres. So this is one of the guys that assists with pronation. We've talked about a couple that assist with supination. One of the important things before we do the cutaneous innervation is the muscles of the thumb. There are 3 thenar muscles, 3 muscles in the thumb, forming this enhanced area, this enlarged area of the thumb. And they will be important muscles for the function of the hand. So what the muscles are, those 3 thenar, is there is a short flexor of the thumb called a flexor pollicis brevis, and it does flexion. There is another short muscle that does abduction of the thumb. So that's abductor pollicis brevis, telling me there will be a longus of each of those. So flexor pollicis brevis, abductor pollicis longus. The flexor pollicis brevis, again supplied by this branch of the median, we call the recurrent branch of the median, whereas the flexor pollicis longus is in the forearm, sitting deep in the forearm, and it'll be supplied by another branch of the median nerve we call the anterior interosseous branch. So again, flexion of the thumb. The important muscle, most important muscle that exists here is called the opponens pollicis. What that does is it takes the metacarpal of the thumb and it allows it to move across the palm of the hand, so that we can oppose the little finger. So that process is called opposition. There is also an opponens of the little finger, opponens digiti minimi, that allows the metacarpal of the little finger to move a little bit toward the thumb. So that action is very important, and that action is critical in grasping motions that we can do at the hand. If we lose the opponens pollicis, the thumb is laterally rotated and will be in roughly the same plane as the palm of the hand. And if we look at the thumb, we can see that it's actually internally rotated. So when we look at the back of the hand, we can see that the nail beds are on the posterior surface, but when we look at the thumb, we see the nail bed is actually pointing laterally. So not in the same plane as the rest of the digits. It's internally rotated almost 90 degrees, and it's the opponens of the thumb that puts it in that position. There is a branch of the nerve called the recurrent branch of the median that's right there, recurrent branch of the median. It comes down and goes back up to get to these three thenar muscles. So it is very superficial. It is right there in the palm. One can sometimes feel that if you push hard enough. And you can damage that recurrent branch of the median and lose the ability to oppose and have the thumb then in the plane of the palm. And you have what's called a clinical condition called ape hand, ape, A-P-E, ape hand. So ape hand, if you lose the recurrent branch of the median. The cutaneous portion of the median nerve will be on the palmar surface of the hand. Again, the lateral 3.5, so the thumb, the index finger, the middle finger, and half of the ring finger. And the other thing about it is it will send branches that go around so that they get the nail bed of those same digits. So the palmar side, lateral 3.5, and also branches that go around and get the nail beds of the dorsal side, lateral 3.5. So that's what we see there, the 3.5 plus the nail beds. We can see the recurrent branch of the median in this view. So there is that recurrent branch. Here's the median coming deep to the flexor retinaculum, going through the carpal tunnel. So that down in there is the carpal tunnel. So carpal tunnel syndrome is when we have problems that cause compression of the median nerve as it's going through this space. One should look at the bones of the wrist and see that when they are in the wrist, we'll just kind of indicate them this way, they form this depression, if you will, this concavity anteriorly. And through that concavity will be the flexor tendons going to the digits, so we'll have a couple of sets of those going through there. And we will also have the median nerve that's right in that location, all covered over by, again, this flexor retinaculum. So anything that causes swelling in here, sudden weight gain, it's very common during pregnancy, for example. Trauma to the wrist can cause it, obviously. There are some folks that just congenitally, they have too tight a space in the wrist, and they can get carpal tunnel syndrome. Carpal tunnel syndrome will affect the nerve supply to the digits, so the lateral 3.5, again, including the nail beds to the digits. And once this has been around long enough, it can affect the nerve supply, compress the nerve so that the nerve supply to the thenar muscles is damaged. So long-term effects of carpal tunnel syndrome will lead to thenar wasting, and if totally untreated, you can eventually have, again, ape hand, like we talked about previously. And again, to review, the lateral 3.5 digits supplied by the median nerve. If we look at the ulnar nerve, it is coming off of the medial chord. So there is the medial chord. Medial chord we know is from fibers from C8 and T1 going through, again, that medial chord of the brachial plexus. So if we look at the ulnar nerve, it does not do anything in the arm, but like the median nerve is fairly superficial in the arm, can be damaged at that location. Very importantly, it's crossing just behind the medial epicondyle, very superficial in that location. Here is the ulnar nerve, deep to one of the muscles that it supplies, which is flexor carpi ulnaris. And as it goes behind the medial epicondyle, that ulnar nerve actually courses through the tendon of flexor carpi ulnaris and can be compressed by tendinitis at that location. So damage to the medial epicondyle, falling on the elbow, hitting the elbow on the edge of the desk or whatever, you can damage the ulnar nerve, but it can be chronically compressed by damage to the flexor carpi ulnaris specifically, or the four tendons coming off of the common attachment to that medial epicondyle. So there are four tendons that attach there. There'll be pronator teres, flexor carpi radialis, palmaris longus, and this one, flexor carpi ulnaris. So the nerve goes through those. We know, again, the nerve is going to be comprised of spinal segments C8 and T1 because it comes from the medial chord. Again, courses behind that medial epicondyle with its companion superior ulnar collateral artery. At that location, behind the medial epicondyle, it is the most commonly injured nerve of the upper extremity. So every one of us has hit that nerve in the funny bone area, although it's really not so funny when you do that. When one gets is a little aware of the distribution of the ulnar nerve hitting that particular location, you can really track the ulnar nerve in its distribution down to where it supplies the cutaneous portions to the medial 1.5 digits, as we will see. So going through the flexor carpi ulnaris can be compressed by tendinitis of that common flexor tendon. It supplies 1.5 muscles of anterior forearm. So flexor carpi ulnaris is the one, so flexor carpi ulnaris, and it supplies half, strangely enough, of the flexor digitorum profundus muscle that goes all the way down and attaches to the distal phalanx of the ring finger and little finger. So testing for the function of this guy, you can test for flexion at that particular interphalangeal joint. So the distal interphalangeal joint of those two digits is through the flexor digitorum profundus supplied by the ulnar nerve. And here it's the median nerve that supplies profundus. So median nerve to these two digits, ulnar nerve to these two digits, tested by testing the ability to flex at flexor or through flexor digitorum profundus at the distal interphalangeal joint. It's the only one that crosses that joint. So those are the 1.5 digits. The flexor carpi ulnaris, 1.5 muscles. Flexor carpi ulnaris and flexor digitorum profundus being the half. Unique situation, dually innervated muscle. We will see some others in the body as well. Cutaneous distribution, the medial 1.5 digits of the hand on both sides, as seen again in this view. Palmar side and dorsal side. And the branch that gets the dorsal side is seen right here coming off of the ulnar nerve. It then travels around posteriorly and will get, again, the medial 1.5 on the dorsal side. But it doesn't get the nail beds. The nail beds are supplied by the branches that go around from the palmar side distribution, just like what we saw with the median supplying the nail beds on the dorsal side. Same situation. There is a region called Guillen's tunnel, and that tunnel or canal is where the ulnar nerve will course as it goes across the wrist. Not usually the problem that you have with carpal tunnel. And the reason is there just aren't as many things in that particular location that can cause damage to or compression to the nerve at that location. But just slightly in this area, there is a bone called the hamate. And that hamate bone has a hook on it. It has an anterior extension, a slight hook on the hamate bone. And the flexor retinaculum attaches to that hook of the hamate. Falling on the palm can break the hook of the hamate, which lives right here, and damage the ulnar nerve. So the hook of the hamate is an important structure, the hamate bone with its hook. So here we can see, again, the ulnar nerve in Guillen's canal or tunnel, the distribution of the ulnar nerve to the medial 1.5. Those branches on the palmar side, again, give branches that go around and get the nail bed, and you can see an indication of those branches going around. The hamate bone is going to be located right at about that location and can damage, again, the ulnar nerve if fractured. This shows you the distribution of the cutaneous nerves. These are on the palmar side. These are on the dorsal side. So if this were, say, the index finger, this would be radial branch. This would be a median branch. If this were the little finger, then this would be an ulnar branch, and this would also be an ulnar branch. But nonetheless, the branches on the dorsal side do not get the nail beds, but the branches from the palmar side come around and get the nail beds. So the dorsal digital branches, again, on each side, you can see what happens with those. And the branches from the palmar side will go to the nail beds. This shows you what we previously mentioned, the 4 branches going down along each digit, regardless of which digit we're talking about. There will always be 4 branches. So if one is trying to remove a splinter from under a nail, or remove the nail, or drill through a nail to relieve a hematoma deep to it, for example, when one smashes the finger with a hammer kind of thing. You need to realize that you've got branches going down both sides. Even though the nail bed is going to be supplied by the branches from the palmar side, one doesn't know exactly how far down those on the dorsal side go. So it's important to anesthetize all 4 branches, all 4. Not difficult, but very important. The cutaneous distribution from named nerves is indicated here. So we're going to have the medial branch, medial and brachial cutaneous branch, medial antebrachial cutaneous branch on the medial sides. We're going to have on the lateral side, branch from the axillary here. Radial peaks over on the lateral side there. The musculocutaneous gets this region. Then we get down into the hand on the palmar side. That's median, and that is ulnar. If we go on the dorsal side, again, very similar situation. We see the axillary up in this region, the radial that goes down posterior arm, posterior forearm into the hand, musculocutaneous here, medial cutaneous nerve of the forearm there, and then the ulnar down in this region. So those are the named nerve branches. But remember, each nerve, each named nerve has fibers from multiple spinal segments. So the ulnar nerve, for example, fibers from C8 and T1. The median nerve, see from C5, 6, 7, 8, and T1. Radial, the same. So the key to remembering the situation is that these named nerves have fibers from multiple spinal segments. They get contributed into that through the brachial plexus. But as these nerves go into the extremity, they don't distribute those fibers from each of the spinal segments to every single location the same way. So fibers can get distributed C5 here, C6 there, C7 here, C8 in a different location, etc., depending on what the nerve contains. So even though we have our named nerves that are distributing the spinal segments or carrying the spinal segments, they don't distribute them across the board to a single location. And this will become more obvious in this particular view. So, for example, we know that the axillary nerve has C5 and C6. But we see with cutaneous distribution that the axillary nerve gives to the skin C5 fibers on the more anterior aspect and C6 fibers, seen in this particular view, and the more lateral and posterior components. So axillary nerve, C5 and 6, but it doesn't distribute 5 and 6 here as well as there. So we can see that, for example, if we look at the hand, we knew that the median nerve, which again has fibers from C5 to T1 in it, will, when it gets to the skin, we know that the median nerve supplies the lateral 3 1/2 digits. But again, as it gets to that skin, it doesn't supply all spinal segments that it has to those same or distinct regions of the digits. So what we do see is that it distributes C5 fibers to the thumb. C6 fibers, pardon me, my mistake. C6 fibers to the thumb. C5 is up here. C7 fibers to the middle finger. So let's say that again. When we get down into the hand, the median nerve that has fibers from spinal segments C5 through T1 does not distribute all of those spinal segments, all of those fibers from individual spinal segments to all of the regions that it supplies. So again, looking at the hand, we see the thumb that is supplied by the median nerve from a cutaneous standpoint, and it distributes C6 to the thumb. But it distributes C7 to the index and to the middle finger. So we get what's called a dermatome. A dermatome pattern. We see that in a segmented fashion on the thorax, anteriorly and posteriorly via dorsal rami, anterior and lateral via ventral rami. And we see that same dermatome pattern even into the extremity. It's just that it's a little bit distorted because of the outgrowth of the extremity. So we do have segmentation that occurs when we look at the chest wall. We have segmentation that occurs when we look at the extremities, just a little distorted. In the case of the chest wall, we have single individual nerves supplying each segment. When we look at the upper extremity, we've got the branches off the brachial plexus that are going downstream, but when they get to the skin, and also when they get to the muscles, they send some specific fibers from specific spinal segments to distinct regions. So it's important to understand the difference between named nerve distribution to the skin and spinal segment distribution to the skin, creating the dermatome pattern, because those things are very important in diagnosing lesions. So if you have loss of cutaneous innervation to the thumb, do you have a median nerve injury or do you have a C6 injury? If it only affects the thumb and it doesn't affect the other digits, it's probably a C6 injury that happened way up in the neck. So knowing the history of the particular injury, damage, trauma to the neck, a blow to the neck or whatever it happens to be, stretching those spinal segments can create a C6 injury versus a median nerve injury, let's say by a blow to the medial aspect of the arm or trauma in the cubital fossa. But that would affect a wider distribution, more than just a single spinal segment. Again, a very, very important concept. So if we look at this distribution from a sensory standpoint, looking at individual spinal segments, again, so that we understand the sensory innervation, we can see that C5, which is carried by the axillary nerve, but C5 fibers get distributed to the skin of that anterior shoulder. So numbness here, C5. Numbness all around, axillary nerve. If we get down into the hand, again, C6 is going to the thumb. So if you've got a thumb numbness, it's a C6 injury. It's not a median nerve injury. Median nerve would affect the broader distribution to the hand. If it's C7, the best way to test it is through the middle finger. As the nerves come down more distally, those spinal segments get distributed more separately, if you will. So it's easier to test those downstream. You can see that some of those spinal segments are indicated here in the forearm and even in the arm, but it's much easier to test them down more distally where they separate from each other better. So C5, anterior shoulder, C6, thumb, C7, middle finger, C8, little finger, and the medial side of the hand, T1 back up towards the axilla. So that's the cutaneous distribution of individual spinal segments. Again, different from the cutaneous distribution from named nerves. If we look at motor innervation, not cutaneous, but motor innervation, in other words, how does it affect function if we have damage to an individual spinal segment? If we affected C5, abduction would be most affected. So I'm not saying that it's only C5 that produces abduction, but it's mostly C5. So damage to C5, you would expect numbness to the anterior aspect of the shoulder and weakened abduction. C6 is elbow flexion. So if we had a C6 injury, we would expect weakness to flexion at the elbow. We would examine or expect damage to the sensory innervation to the thumb. If we have a C7 injury, most affected will be elbow extension. And we will expect, again, cutaneous effects to the middle finger. And if it's C8, it's finger flexion that is most affected. And again, we would expect trauma to or numbness of the medial aspect of the digits, in other words, to the little finger. And then if we look at T1, that's finger abduction and adduction. And from a cutaneous standpoint, we're back up to the axillary region. So if we look at the motor innervation, we actually sequentially have a salute. So C5 is flexion, C5 is abduction, C6 is elbow flexion, C7 is elbow extension. So there's the salute. Abduction, 5. 6 is flexion. 7 is extension. And then we have finger flexion for C8. And we have abduction, adduction of the digits for T1. So it's kind of like salute and wave goodbye is the way to think of that. So Again, from a motor standpoint, C5, C6, C7, C8, and T1. From a cutaneous distribution, C5, 6, 7, 8, T1. So if you put those together, that's what you should expect. Again, a C5 injury, you should affect the anterior aspect of the shoulder skin and shoulder abduction more than any other action. Very important to remember that and be able to separate a spinal segment lesion from a named nerve lesion. So that's the simple way to do that.